Thank you very much, Richard and Pat, and it's a real pleasure to be here to be speaking at the Senior Summit this evening. Many thanks for coming out tonight and taking an interest in this issue. I mean, I always say that I'm not surprised that we're all taking an interest in this issue because, frankly, we're all going to get older. Some of us are closer than others to that, and so therefore we all have a vested interest in making sure that Ontario can be the best place to grow up and grow old. So I look forward to sharing with you over the next few minutes just a little bit about the journey that we've been on as a province and some of the great work that's occurring overall. And you've already heard about some of the great work that's happening here in Sudbury with Health Sciences North and the local community partners. So in terms of our context, understanding the overall journey here, we know that 14.6% of our Ontarians and actually Canadians are right now 65 and older, yet they account for nearly half of our health and social care spending. And that's understandable. I had a 92-year-old patient in clinic the other day who was saying, "Why is my knee starting to have some arthritic pain in it?" And I said, "It's called mileage, right?" I said, you know, some knees weren't built for 92 years. I said, our cars don't even last 10 years now. So your knee that's gone 92 years without arthritis, that's a pretty big achievement, right? But the key is we know that as we get older and we have more wear and tear on our bodies, we're more likely to develop health concerns. Some of us have a single health concern. There are some of us who have many health concerns. And sometimes we have more challenges in terms of needing social supports as well. So it's understandable but that a small proportion of our population is older, yet represent some of the greatest users of our current health and social care services. But this is what's getting everyone excited right now because, as we know, we are aging as a society and that Canada and Ontario's older population is set to double over the next 20 years, while those who are 85 and better are going to quadruple in numbers over the next 20 years as well. So we certainly have a demographic imperative on our hands, and for those of my colleagues who I like to call apocalyptic demographers, right? Mostly bank analysts, you know, they say, you know, with the aging of the population, this older population that certainly built our country and made it what it is today, well, they're going to actually bankrupt it, right? Because they're using so many services and therefore they're going to cause all these problems. Well, you know, hold on there, right? Because I'm, as some of you who know me, and many of you will get to know me over this presentation, I am one of these optimists who actually see this as a tremendous opportunity. And why do you say that? Well, first of all, a friend of mine the other day, one of my colleagues, gave me a little bookmark from a group of, you know, we have Friendly for Seniors as a local organization. Well, their equivalent, which is a bit more radical in the United States, are called the Grey Panthers. Okay, and the Grey Panthers, they have many great slogans, but they put one on a bookmark, and it says, "Aging is not a disease, it is a triumph." Right? I like that. Absolutely. So that's a good thing. And number one, we have to, why do they say it's a triumph, right? Well, in 1900, if you were born in Ontario, your life expectancy would be a whopping 51 years of age. And actually, when we actually founded Medicare in our province over 50 years ago, the average age of a Canadian at the time was 27 years of age. And life expectancy, by the way, was 67 years of age. So sad to say that many of us in the room wouldn't be here at the time. So you can imagine when we designed our healthcare system, when the original hospitals that came together to form Health Sciences North were created, they were created, understandably, with a younger population in mind. Younger population, probably, what is the average 27-year-old go into hospital for? Maybe to have a baby, for example, or maybe because they have, you know, they need surgery or something like that. So one issue to go in and come out with, but not necessarily the traditional users now who happen to be older adults. So I always say the patience of change in the system hasn't, because nowadays the typical Canadian is 20 years older than they were many years ago when we created our system, and our life expectancy is now 79 years of age for an older man and 81 years of age for an older woman. So we have a tremendous amount of opportunity to do better now. This is the data in the Toronto Central LHIN. This is actually where I work, and as many of you know, we have 14 local health integration networks. The Toronto Central LHIN is one of 5 LHINs that work across the Greater Toronto area. And as you'll see from the data, it shows that we have a slightly younger population, signified by 14% of our population are 65 and better, yet they account for 21% of the emergency room visits, 37% of our hospital admissions, and 75% of our inpatient rehabilitation days as well. And that red line represents that term, alternate level of care. That's the term given to people who are waiting in hospital to go home with home care or to go to a long-term care home. And we know that 83% of those who are alternate level of care patients are actually those who are 65 and better. The column on the far right represents those older Ontarians, or those older Torontonians, if you will, who are 75 and greater, and you'll see that they represent the majority of the individuals in those categories as well. So of course you're saying, well, that's great, Dr. Sinha, you're from Toronto Central, but we're actually living, if you checked when you got off the plane today, in the Northeast LHIN, right? So actually, here's your data too. And here's my party trick. Oh, can't see the slide. Well, the party trick is, if you look back, I can't switch the slides back and forth here, but the key is, if you go back and forth, the key point is it's pretty much the same story all across the province. And so I think that's a real key point here, because while we recognize facts that the northeast region of our province covers 40% of Ontario with only 4% of its population, 25% of our population are francophones qui parlent français. This is a big issue. We are very different in many aspects in that way, yet the same aspect is that we are all having the same challenge of aging, and aging in relation to a system of care that was designed for a much younger population. This is the data across Ontario as a whole, and we'll see that overall across Ontario, older adults represent 42% of our hospitalizations and 60% of our inpatient bed days in total. And so you can imagine why, when I moved to Ontario to do my internship in Toronto, and 60% of my patients on my list every day were 65 and better, you have to appreciate that growing up in Winnipeg and coming here, I realized, well, I think in Ontario, it must be when you turn 65 that you sell your home and you move into a hospital. I have the data to prove it, ladies and gentlemen, right? But apparently that's not the case, as many of you have told me as well. Let's see if I can get this slide to move forward for us. There we go. Okay. So this was actually a study done by Joseph Walensky, and he was a gentleman who actually participated in work called the American Longitudinal Study on Aging. And he simply wanted to ask that question that I was really curious about. I discovered this paper after my internship year in Toronto because I was really curious about that question. And he simply asked the question, how often do older adults use hospital services? So he actually followed a cohort of 7,500 older adults over a 7-year period, just to see how often they hang out in the hospital, how many are actually living in the hospital. And what he found was this. He found that the largest piece of the pie, the 42%, never actually went close to the hospital over the 7 years. They were maybe participating still in the workforce, they might have been playing with the grandkids, maybe traveling the world, volunteering, doing a whole bunch of things, but certainly not spending any time near a hospital. Another 24% represented those who used the hospital maybe once over the 7-year period. And that might have been, for example, because they needed an elective knee replacement. You know, maybe my 92-year-old when she's 95, that might be her, for example, who needs that elective knee replacement so she can continue doing all the great things that she does. And then the rest of the pie that would add up to 100%, the rest of the people would have represented those people who used the hospital 2 or more times over that 7-year period. And in particular, Walensky focused on those two small slivers in particular. One which he called the inconsistently high users, and the other one which he called the consistently high users. And so what do we mean by the consistently high users? Well, David talked about having specialized clinics for individuals with diseases like congestive heart failure or chronic obstructive pulmonary disease, because these are individuals who actually have health conditions that can flare up pretty easily if they're not managed very carefully in the community in particular. And so these individuals tend to enter hospitals if their care isn't managed well on a pretty frequent basis, on a consistent basis. The other individuals are what we call the inconsistently high users, who may have those diagnoses. But then if you also throw in something like dementia, for example, we know that that increases your risk of hospitalization by 50%. A mental health condition can also do the same thing as well. So people who use the hospital often, but not necessarily in a predictable manner. And basically what Walensky was able to show me was actually that, first of all, most people do not live in hospitals when they become older, and that only a small proportion of older adults are actually extensive users of our hospital services. So then he actually went one step further, and this was actually revolutionary to my thinking, because he said, so what categorizes that 10%? Those 10% who are using the hospital all the time, what categorizes those individuals? And what he found were there are three factors in particular that define that population. The first factor was what we call polymorbidity. So this is a fancy term meaning having 4 or more chronic health conditions. So remember we were talking about the patient who has congestive heart failure. Well, I bet you if you have congestive heart failure, also known as CHF, you probably have an underlying heart disease, you probably have high cholesterol, possibly have high blood pressure, you may have diabetes, for example. Well, that's already 4. You just need 4 chronic health conditions to get yourself in this club of being a polymorbid patient, for example, meaning multiple health conditions, okay? The next aspect is something we call functional impairments. So this is a real focus of the work that Dr. McElhaney, my colleague and actual long-standing mentor before she came to Sudbury. I was glad that we got her all the way from Vancouver, British Columbia, to Sudbury here. This is a huge win for the North. But basically, when we talk about functional impairments, and this is a real focus in Dr. McElhaney's work right now with the coach team, it's really focusing on those 6 activities of daily living. So what do we mean by that? Well, that's what we measure function as geriatricians and healthcare professionals. And these are basically the 6 things you probably did in this order in the morning. You probably transferred from a lying to a standing position, getting out of bed and getting up. You walked over to the bathroom, you toileted yourself, you bathed yourself, you dressed yourself, and then you ate something. And we know these individuals struggle with 1 or more of those activities. Maybe they need the help from the CCAC once or twice a week to get a bath, for example. Maybe they need help with dressing, or they need a mobility aid to walk around. Then the third factor is something that I like to call social frailty. So people often say, wait a minute, okay, we were with you up until this point, but now you're crazy, right? Because what do you mean by social frailty? We all have these things, right? We have our iPhones, our Blackberries. Some of you are probably right now going, Dr. Sinha is boring, so you're twittering that to your friends. You might be on Skype with your grandchild. You might be emailing those pictures. So you're saying we're more connected with our families than ever before. However, remember this, or think about this. We are less likely now, compared to 50 years ago when we were 27 years of age and we weren't going to live longer than 67, we were more likely back then to be living in intergenerational households. We were more likely to live in intergenerational communities. We were more likely to be going to church, synagogue, mosque, and be with each other, or to the Legion or to the Steelworkers Club here, and belonging to communities where we actually had physical contact with other individuals, where we'd always be able to make new friends, so that if you actually had a challenge, you could actually have someone you could call on to come over and do a favor. We heard the story, Dorothy's story earlier today, and there Dorothy was saying that, while she didn't get her care set up within 40 hours, she said, I at least had friends that I could call on to come over and help me if I need to in the meantime, right? And that's important, because I think about my mom and dad. They're both in Winnipeg, aging in place there, but they've got a son in Baltimore and a son in Toronto. And I feel better that there is an app now to get groceries for them if I need to on the computer. But, do they have someone around the corner who can shovel their driveway? And we know how important that is, basically, to get out of our houses. So thinking about these aspects, I always think about these three issues whenever I design a new model of care or I think about those greatest users. Because if we're not thinking about these three issues, how do we manage all of the medical issues together? How do we think about their function, their ability to mobilize and get around? And how do we think about their needs and their connections within our society? We're missing key pieces of the puzzle that really mean the difference between staying healthy and independent or perhaps a less fortunate outcome. So we also know that as we get older, so we also become different than when we were younger, in a sense. So just like I think we now have well established that children are not just little people or just younger versions of us, if you will, we also know that elders, as we get older, are going to increasingly experience certain things. So we know Dorothy told us that she has visual challenges, and we know Dorothy's not alone. 25% of older adults actually have visual challenges. 25% of older adults have hearing challenges as well. We also know that as we get older, our memory actually becomes a little bit slower. That's actually normal. But dementia, for example, is not a normal part of aging, but it is more likely to occur as we get older as well. We also know that we have skeletal and muscle changes. And what do I mean by that? Well, how many of you have heard of osteoporosis? Okay, so osteoporosis is brittle bone disease, because as we get older, as we get away from our late 20s when our bone and muscle mass is at its peak, our bones get thinner as we age, putting all of us at risk. So all the older women in the audience, your chance of osteoporosis, 50%. Gentlemen, you're not far off, because 25% of you will develop osteoporosis, and that can lead to a fracture in particular. So the key thing is we also know that as we get older, we have less muscle cells, if you will, and we can actually have thinning of our muscle cells, and in a sense that creates, not like osteopenia with our bone cells, muscle cells is called sarcopenia. Meaning that that bone and muscle strength that we had, that mass that we had when we were younger, means that if we lose some of it as we get older naturally, it means that it becomes harder for us to push things, to lift things, to pull things. It means why these chairs are not senior friendly, because some of the older people who have to try and get out of the chair, they need to use their arms to push themselves out to recruit extra muscles in that. That's why Dorothy knew exactly what to do when she was in hospital, because she said it wasn't a routine practice, not yet in the hospital, to actually mobilize all the older adults, because she knew if I don't move it, I lose it, basically. So remember what Dorothy said next time you go to the hospital, okay? And so the key thing is that there are many things that happen to older adults as we get older, and we need to consider these things as well, because it really impacts us in a number of ways. For example, this is what it's like if we take the visual example. This is what it's like if you have normal vision, for example. For those of you who have normal vision, this is what it's like when you see this picture. Now this is what it's like if you're looking through the lens of an individual who has a cataract. Okay? Now this is what it's like if you have age-related macular degeneration. And now this is what it's like if you actually have glaucoma. So imagine now being one of those individuals with those three issues, and then you're also having your challenge with your vision. So you can start understanding why now it's really important that even subtle things like the way we design our street signs and our signage, where we actually use contrast, because if we use dark colors if we use dark colors versus light colors, the more contrast we have, the easier it is to see if you have visual challenges, for example. So cities, for example, and organizations that are thinking about those elder-friendly environments, not just in a hospital, but out on the streets, for example, are thinking about how do we change our signage around? How do we build our park benches so that they are elder-friendly, that they have armrests, for example? Because those subtle design changes, they don't actually cost any more money to do, but they make our environments more elder-friendly in particular. So now you imagine that you have some of these issues, and you might be one of those individuals with those top three concerns, and now you're trying to navigate the system of care that we actually have. And I think, again, Dorothy told us her story about how she had 4 pages of phone numbers as she was trying to figure out how to get some care organized for herself. And she really spoke to one of the things I heard most from our older Ontarians, that we do very little to empower patients and caregivers with the information they need to navigate the system in an easy way, right? So the key is, you know, we have $48 billion of healthcare services that we fund in this province, and I'll tell you a secret here. Most of us don't even know the local services that are available to us. We actually surveyed 1,000 caregivers, no matter what age, looking after an older adult in Ontario. 50% of them told us they didn't even know what the CCACs were, and they had no clue what they provided. A number of caregivers told me, Dr. Sinha, remember that caregiving is a 24-hour, 7-day-a-week job. So again, if they didn't aware that the CCAC has respite services or personal support worker services, other things like that, you can imagine that we're doing a real disservice letting people know the things that are actually available or the other things that are available as well. There's lots of healthcare practitioners, to be perfectly honest, who aren't even aware of what other healthcare practitioners are doing. So we need to do a better job to make sure that we make information about what we do and what we provide better accessible for both caregivers but older people, so that Dorothy really should have just been able to call one number and had her problem solved instead of 4 pages of numbers in future. The next issue is we also are kind of a funny place because, you know, while we have this older population who are now the majority users of our healthcare system, we still do not require in this province any of our current or future health and social care professionals to have any training in the care of the elderly. So let me tell you a secret. You know, NOSM, our Northern Ontario School of Medicine, our latest school of medicine, just like all the other schools of medicine in Ontario, they require every medical student to get a very good training in pediatric medicine. Well, is that great for all of you in the audience? Because I'll tell you, no medical school requires any training in geriatric medicine. No school of nursing. No school, go on and on and on. That's a concern, because who paid for my medical education at Western? Yeah, the taxpayers. Basically, you did. Thank you very much. But so if you were paying for my education, and thank you, might you have a public interest to make sure I learned how to actually care about you? Yeah, pretty much. So maybe we need to do something a bit better about that as well. We also don't really talk to each other well within and between sectors and professions. One thing that we heard a lot as we went around was a lot of primary care physicians said, we're not really aware of what the care coordinators are doing with our patients through the CCAC. We also had CCAC care coordinators who tell us we try and connect with primary care providers, you know, but we find it challenging as well. So, you know, Richard is one of the CCAC CEOs, and I've really challenged the CCACs and the primary care groups to say, you need to communicate with each other because frankly, your patients are expecting you to, so how can we get this right? Because they deserve better. They deserve the best possible communication, the best possible care. And that will avoid us from working in silos and making us work more as a system of care. And then we have to make sure that as we plan for our healthcare needs, we often are planning for today, but not really thinking about tomorrow. So we know, it's no secret here, that we have 1.9 million older Ontarians today. We're going to have 3.8 million older Ontarians in 20 years. So maybe we need to have more home and community care services. Well, not maybe, we know we need to have more home and community care services, but maybe we need to figure out what are the other things and plan accordingly as opposed to reactively as we organize our services as well. So why should this matter? Because ISIS is a research group in Ontario that looked at the data amongst those who are 65 and better in our province, and they found the 10%, remember that 10% I talked about, who have all those challenges and are navigating the system, well, they actually account for 60% of the healthcare spending in our system for those who are 65 and older overall. But at the same time, the least complex 50%, the healthiest 50% of our older adults account for only 6% of our healthcare spending. So when I showed this data to our Minister of Health, she said, Samir, this is simple. This is what the senior strategy has to deliver for us. We need to know how we can do better to help people stay healthy and independent, you know, so that we can grow that 50% to 70%. And maybe we're not actually running the best healthcare system that we should be having. Maybe we need to be doing things differently, more integrated care, so that it's not so costly for the overall system, but frankly, these patients are actually getting the care they deserve, and better integrated care in particular, so that stories like Dorothy become a story of the past and not an ongoing story in future. So the key is that the way in which our cities, our communities, and our healthcare systems are currently resourced and organized and designed often disadvantages older adults with chronic health issues, is what I argue. And at the same time, as Ontarians, our care needs, preferences, and values are changing as more of us are wanting to age in place. So this is actually one of my patients. This is actually Mr. W. He's 103 years old, okay? I know most of you wouldn't have guessed that. And if you want to know his cognitive abilities, you just take a look at the window ledge there and you'll see his 2 Rubik's Cubes there. So Mr. W is 103. He's living in his own home where he wants to be. He gets some support from the CCAC every day to help him with a bath, to help him get dressed every day. And he's very keen about aging in place and staying in his own home. So why develop a strategy? Well, in 2011, the provincial government announced its new vision to make Ontario the best place to grow up and grow old in North America. And given our current and future challenges, the development of a senior strategy was started last year at the beginning of 2012 to help establish sustainable best practices and policies at a provincial level, given that from those earlier slides you saw, we are all united in this issue overall. And the key was, Ontarians told us through this process that they want to make sure that while we have a significant financial deficit that we're trying to deal with at the same time, that as we think about how we reorganize our healthcare system and the services overall, that we make sure that we focus on these key priorities. Ontarians told us that these were the principles they wanted us to adhere to in a strategy: equity, quality, access, value, and choice, and make sure that we focus on policies that really aim to help Ontarians to stay healthy and independent and to stay at home for as long as possible, which is something I've heard repeatedly over today, is what everyone has been telling me is their wish as well. So I want to say thank you to those of you. I know there's some of you in the audience who did participate in our consultations last year. I didn't meet a lot of people. I met a lot of people, but there were also thousands of people I never had the privilege of meeting in person. We had over 5,000 older Ontarians who participated in our surveys, who came out to our engagement sessions, and last year I did a big blitz around the whole province, going to every single region, and I've actually been to all the First Nations coastal communities in James Bay, been to North Bay, Sudbury, the Sioux, etc., listening and hearing what older Ontarians and older Northerners told us was important in particular. And we also were able to engage many stakeholder organizations that have, that are providing care or that have an interest in advocating for older Ontarians. CARP in particular was a major player in helping us understand and galvanizing the support of their members, for example, to make sure that we got the information that older Ontarians felt we needed to hear as well. And all of that culminated in the final report that I was asked to deliver to the Ministers of Health and Long-Term Care and the Minister for Seniors, which was called Living Longer, Living Well. The overall report, if those of you who are looking for some easy bedtime reading, it's 233 pages. It's 233 pages. The minister's like, wow, you wrote another doctoral thesis. And I said, we've got a lot of issues that we need to work on here. And you can see that our strategic themes and areas of focus, these are the 12 chapter titles, if you will. And these really talk about, the first one that you'll see is really talking about supporting the development of elder-friendly communities. How do we make sure that our cities and communities are ones where we feel that we can age in place? Because it wasn't just about healthcare that it was important. People said we need to have affordable housing. We need to have accessible housing. We need to have transportation services, because older adults tend to outlive their decision to stop driving by 10 years. So we need help to get around our communities. I've talked to your mayor here in Sudbury, who understands these issues. She started her career working at Pioneer Manor here. And so she understands these issues as well, and I understand there's some work now accompanying to start developing a senior strategy for Sudbury as well. But then the other aspects are, people said, don't just create a system for me when I get sick. How do you help me stay healthy and well? What are the things I can do to stay active and engaged and healthy and independent? And then what do we do to improve our primary care, our home and community care, our long-term care, all the other aspects of our healthcare system? Also thinking about important issues like ageism and elder abuse. These are still big issues in our society. Thinking about the needs of specialized, special populations, for example, our Francophone communities, our older Aboriginal peoples, those older adults who are lesbian, gay, bisexual, or transgender. How do we support their needs as well? And then how do we measure success? What are those enablers that we allow ourselves to actually implement a strategy? So one of the things I think is a major strategy is maybe we need to ensure that every health and social care provider in Ontario actually knows something about caring for older adults. That way, when Dorothy was in the hospital, everyone would be saying, Dorothy, move her to lose it. And she's like, I'm right there with you, right? So these are the key things. We need a well-educated workforce. We need to know the metrics that we're going to measure our success in order to move forward as well. There were a total of 166 recommendations. There were 33 recommendations that now sit with our new Ministry for Seniors. One of the responses to the report was the Premier Wynne, created first a standalone Ministry for Seniors, the first time we've had that in the province. And they're in charge of working with 7 other ministries, the Ministry of Housing, the Ministry of Transportation, et cetera, on helping to implement the 33 non-health, if you will, recommendations. And there were 133 recommendations that the Ministry of Health is actively implementing right now. This individual wasn't able to be with us tonight, but some of you will recognize her as Madame Louise Paquette, who is the CEO of the Northeast LHIN. Louise is a tireless champion for seniors and their needs, and she actually helped organize an opportunity for me to come with Dr. McElhaney, Dr. Joanne Clark, and others to go up to the First Nations coastal communities of James Bay to meet with those elders to understand what they needed. Mr. W at 103 thought that he would win the record of being the oldest respondent in the senior strategy. He was actually beaten out by Miss Margaret Wabenow here, who's 109 years old, who was in hospital in Moose Factory, and Louise met her on the day that she was being discharged from the hospital. We met her 6 months later at the local elders gathering place in Moose Factory, where she was involved in a fierce bingo competition. Okay? So what defines an elder-friendly community? Well, it's a community that recognizes the great diversity amongst older persons. It promotes their inclusion and contributions in all areas of community life. It respects their decisions and lifestyle choices, and anticipates and responds flexibly to aging-related needs and preferences. This is the World Health Organization definition of an age-friendly city and an elder-friendly community. And we talked about this in the report, and we talked about the 8 aspects. We talked about transportation, housing, social engagement, participation, all these factors, including community health and social services, that all together really make our communities places where we feel comfortable that we can actually age independently and more successfully. I'm now going to leave you just with a few more slides, just talking about understanding some of the thinking behind this in terms of understanding our choices. Because as we start thinking about developing a senior strategy and moving things forward, it really is going to be about us making choices to develop the province that we want to actually move forward. So you all are experts now in knowing that because we have an aging population, and because with mileage we're more likely to accumulate health and social care issues, that as we get towards our later years, on the right side, that's where our actual costs are more attributed to in our healthcare system. And you'll also see here that that next line is what it'll cost us, where our costs will be attributed in 2030 when we have double the number of older Ontarians in our province. That cost differential between the $48 billion we're spending today is $24 billion more that we're going to have to find when we currently have $11 billion deficit at the moment in order to meet the needs and keep our system sustainable. This is if we do nothing differently, though. If we do absolutely nothing different, we run the system that was meant for a younger population. Very few Ontarians actually see this slide, but this is actually how we divide our $48 billion healthcare budget. And you can see it's mostly allocated to places where we initially put our focus on many years ago. But I want you to look at the bottom right-hand corner, because you're going to see 2 slices there. We actually, for every $4 we spend on long-term care services, last year for 100,000 Ontarians in the province, we actually spent $3 providing home and community care to 1.2 million older Ontarians. What are we learning in Ontario? Well, we're learning that right now, well, I have a question for you. How many of you aspire to end up in a long-term care home? Please raise your hands. I don't know if you heard the question. I'll say it again. How many of you aspire to end up in a long-term care home? Okay, well, we have a bit of a problem here, you see, because our traditional planning practices were going to assume, or, Richard and I grew up in a system that assumes that you're going to end up in a long-term care home, that you're not going to need CCAC services or home and community care. But apparently, people want to age in place in their own homes. So right now, we have 78,000 long-term care beds, and we believe that we're going to have to build, we're going to have to triple the number of beds. But every single home, every single bed we build in long-term care costs $150,000 of taxpayer dollars. And then it costs $47,000 a year from the taxpayer side, not the part that the person pays themselves, to actually stay in a long-term care home bed. Okay, that's a huge amount of money that we're going to have to spend. That's that $24 billion cost differential. That's a large part of it in particular. But what I started learning is the supply of long-term care beds doesn't necessarily equal the demand for long-term care beds across Ontario. I'll give you the example of the Mississauga, Halton, Lynn. They actually have the lowest number of beds in that region than any other part of the province. Far fewer beds per capita than the Northeast or the Northwest. But they also have the lowest demand for long-term care. Why is that? Well, I know that on the Lynn list there where people were saying, what do we need to help age in place? People were saying supportive housing. They invested 2/3 of their dollars in building 1,000 new supportive housing beds or spots. This is where a person, an older adult, might live in an apartment building where there's a 24-hour personal support worker available who is not side by side all the time, but is available if someone needs help, for example. Or they might be living close to that building and they're within a few minutes of getting the help of that worker as well. By doing that, they actually have the lowest demand for long-term care in the province. And other areas that are investing more in supportive housing are seeing the same opportunity as well. We also know that we still have a system where that 37% of those hospitalized older Ontarians designated as alternate level of care waiting for long-term care are those who could be maintained at home with home and community care supports. So again, an opportunity to do better as well. This is the data for across the country. And you remember how I said for every $4 in Ontario we spend for long-term care, we spend $3 for home and community care. Well, the maple leaf in the middle shows Canada. The yellow bars represent long-term care spending. The blue bars represent home and community care spending. Across the country, we're actually doing better in Ontario overall, because across the country, for every $5 we spend on nursing home, long-term care services, we spend $1 on home and community care services. But I want you to look at the 3 countries that actually have a blue bar bigger than a yellow bar. Those are the countries of Denmark, Poland, and Austria. And on to the far left, you'll see Denmark in particular. So, well, why am I pointing that out? Well, these are the choices and options that we currently have as Ontarians. I can tell you that a day of hospital care costs around $1,000. I can tell you with certainty that a day of care for an older adult at Mount Sinai Hospital, $951 per day. A day in long-term care, you remember $47,000 a year, it's $133 a day. But on average, a day of supportive housing or home and community care costs only $55 a day. This is one of those rare opportunities where actually the cheapest forms of care are actually the care that we actually aspire to actually have. So what is really nice to see is that the political, while we have a lot of political confrontation going on right now in our province, I'll tell you the 3-party platforms last time, the Blue Party was actually saying, build 25,000 new long-term care beds. That's the solution for the older population. The Orange Party was saying, build 12,500 beds and invest in more home and community care. But the party that became the government actually said, let's not build any new long-term care beds, let's start investing more in home and community care. And why is that? Well, they quoted the Denmark model, and Denmark actually avoided building any new long-term care beds over 2 decades. They were exactly in our same fiscal and demographic situation in 1980. And by doing that, by investing much more in home and community care, they were able to avoid building any new long-term care, any new nursing home beds over 20 years, and they actually saw the closure of thousands of hospital beds because they were able to provide more care closer to home. And so that's what the Ontario government has been doing as a result of the senior strategy. Last year was the first budget under the strategy, and it meant that our hospitals got a 0% increase in their budget. They've done that again this year. Last year, doctors agreed to take a 0.5% pay cut. Again, it's about choices, and these are political choices. These are choices that are not always popular, but that managed to get a 4% increase in our home and community care budgets last year, and this year, the most unprecedented increase, a 6.2% increase. What does that mean? That's $250 million more that actually went into the home and community care system. Is it enough money? I don't think so. Okay, but is it a start? Absolutely. But in order to keep increasing that funding towards home and community care, we've got to find the money from somewhere, and we've got to make more choices as well. So is any of this working? Is any of these investments in home and community care working? Well, you've heard about how Health Sciences North was having a lot of challenges with their ALC issues, but the CCACs and others have been involved in the Home First initiative to help more people who are at risk of going into long-term care homes get the care they need to get at home. And we've actually seen the number of ALC patients across Ontario, alternate level of care patients, drop by 17%, while those awaiting long-term care in hospitals has decreased by 32% overall. But so people will say, well, so that means that people are just waiting at home in the community for long-term care because we're still sending people off to long-term care. Well, this is the overall provincial data, which shows that while 25,000 people were on our long-term care wait lists 3 years ago, that number has fallen down to 19,000 people on our long-term care wait list. And the average wait for long-term care is about 6 months in our province overall, on average, in particular. At the same time, we haven't built any new long-term care beds in the last 3 years in Ontario, but the population that's 75 and better has continued to increase. So the actual supply of beds per capita in the older populations decreased by about 3%, but at the same time, the actual demand amongst the 75 and older population for long-term care has decreased by about 7%, and actually the placement rate into long-term care has dropped by about 27% as well, meaning that more and more older Ontarians are actually able now to age in place in their home because we've been making those investments in home and community care as well.